Acompañarnos esta mañana. Gracias por haber madrugado el día de hoy, en sábado, sobre todo después de 2 días de convención tan llenos de actividades. Esta es nuestra 9ª sesión. El día de ayer creo que fue también un éxito, creo que aprendimos muchísimo. Tuvimos 4 sesiones muy interesantes, tanto que las sesiones de preguntas y respuestas se prolongaron durante un buen rato y se prolongaron todas las sesiones. El día de hoy empezamos con una sesión un poco fuera del tema de la interpretación, pero que realmente a todos nos ocupa. Es una conferencia sobre esta epidemia sedentaria que representa el hígado graso. Agradecemos muchísimo al doctor Francisco Durazo, que es médico cirujano egresado de la Universidad Anáhuac de la Ciudad de México. Hizo su internado de pregrado en el Hospital ABC y en el Centro Médico de la Universidad del Sur de California en Los Ángeles, donde también hizo su residencia en Medicina Interna y su posgrado. Perdón. Y su posgrado en Gastroenterología y Enfermedades hepáticas. Tiene estudios de posgrado en el Centre Hospitalier Régional et Universitaire de Marseille, en Francia, en la Hamburg, esa no voy a tratar de pronunciarla, pero en la Universidad de Hamburgo, en Alemania, y en el Hospital General Manuel Gea González, en México. Ha sido profesor asociado de Medicina y Cirugía y director médico del Centro de Trasplante Hepático de la Escuela de Medicina David Geffen en California. Ha publicado decenas de trabajos de investigación en revistas de reconocido prestigio internacional, entre las que destacan la American Journal of Gastroenterology, Liver Transplantation, American Journal of Transplantation, Annals of Surgery and Hepatology, y actualmente dirige el Centro de Trasplante Hepático del Medical College of Wisconsin. Muchísimas gracias. Sin más ni más, le doy la palabra al doctor Durazo.
Good afternoon. My name is Dr. Francisco Durazo. I'm a professor of medicine and surgery at the Medical College of Wisconsin. I'm going to talk today about non-alcoholic fatty liver disease, which, as you know, it has become a public health problem in our society. Actually, the first term that was coined was non-alcoholic steatohepatitis, NASH, by Dr. Ludwig at the Mayo Clinic. It was in 1980. He had a group of 25 patients that had alcoholic liver disease, but without drinking. He's ruled out other causes of liver disease, and he noticed that most of them were obese. 25% had diabetes, another 25% had hyperlipidemia, most of them had hepatomegaly, and their biopsy showed steatosis, lobular inflammation, Mallory bodies, and sinusoidal fibrosis. So much we've learned since the term NASH was coined, and we know that NASH is part of a spectrum of non-alcohol related steatotic liver diseases known as NAFLD or NAFLD. The spectrum of NAFLD goes from simple fat deposition in the liver towards fat with inflammation and to cirrhosis and the development of hepatocellular carcinoma. Deposition of fat in the liver is going to be due to a dysregulation of insulin in the setting of insulin resistance, and the development of fat with inflammation is going to depend on an inflammatory response against neo antigens within the lipid-laden hepatocytes. It is the most common liver disorder in the world, and it's the most common cause of abnormal liver tests in the United States. Its prevalence varies depending on the population that you study, but it goes from 6.3 to 33%, and NASH up to 5%. Alarmingly, in the United States, NAFLD has a prevalence of 46% and NASH of 12.2%, which is worrisome. It usually appears between the 4th and 6th decade of life, and it's an independent risk factor for coronary artery disease and cardiovascular events. It also carries a high risk for the development of hepatocellular carcinoma. And there seems to be a genetic predisposition. There's a single nucleotide polymorphism, the patatin phospholipase A3 or PNPLA3, which has been present in patients that develop advanced fibrosis and hepatocellular carcinoma. And interestingly, this single nucleotide polymorphism is present in 40% of the Hispanic population. There also seems to be a racial predilection, especially in Hispanics. You will see that fatty liver prevalence, it's in males, females, 45%. In Caucasians, it's more prevalent in males than in females. And these are the ones that are going to have the lowest prevalence of fatty liver. We also know that fatty liver is now part of the metabolic syndrome, together with insulin resistance, hyperlipidemia, hypertension, the presence of truncal obesity, and NAFLD or fatty liver. The more components of the metabolic syndrome in any given patient, the worse or the more aggressive the disease, as we can see in this study done by Dr. Dixon. If there are no components of the metabolic syndrome, we see that the risk for NASH is very low. If hypertension is present, it goes up to 30%. If diabetes is present, goes up to 60%. And if both are present, goes up to 80%. The metabolic syndrome usually occurs when the energy supply exceeds the metabolic needs. This is going to trigger triglyceride-derived metabolites that are going to deposit in tissues that normally do not deposit fat. So fat deposition in this tissue is going to trigger insulin resistance, inflammation. This is going to trigger cellular dysfunction and apoptosis through cytokines, through all these cytokines which are going to be part of chronic inflammatory states, which is usually NASH. Cytokines that take place are the TNF-alpha, NF-kappa B, interleukin-1 beta, interleukin-18. And on the other side also, we know that a caloric excess intake is going to increase the permeability of the intestinal barrier. So we are going to have a defective intestinal barrier with leakage of the metabolic byproducts of the intestinal bacteria into the circulation in the form of lipopolysaccharides. And all this is going to trigger the chronic inflammatory states, which is really what the metabolic syndrome is, a chronic inflammatory state. And NASH now it's better called lipotoxic liver disease. The fundamental defect in NASH is going to be insulin resistance, and insulin resistance is going to be due to an inappropriate lipolysis suppression by insulin. So we're going to have an increased lipolysis with increased free fatty acids. Increased free fatty acids are going to trigger increased hepatic glucose output when going through the liver, and this is going to increase the glucose load in the blood. On the other hand, increased free fatty acids are going to decrease the metabolic clearance of glucose by the muscle, and this also is going to increase the glucose load in the circulation. And with a more glucose load, the pancreas will needs to work extra, secreting more insulin. So more glucose load, and the pancreas forcing to produce more insulin, until the pancreas becomes tired and said, you know what, I quit. And that's when diabetes appears. Still, we don't know why some people with fatty liver are going to develop fat with inflammation or non-alcoholic steatohepatitis, and some are going to just stay with simple steatosis without any progression of the disease. This is the two-hit hypothesis, which is the most acceptable hypothesis, that states that uncoupled oxidation and phosphorylation with cytochrome P450 activation and peroxisomal fatty acid oxidation is going to trigger an imbalance between the oxidants and antioxidants. So we are going to have excess of radical oxygen species, and in the presence of cytokines, mainly the TNF-alpha, are going to trigger an oxidative stress within the hepatocytes. And this oxidative stress within the hepatocytes in the presence of fat is going to develop a non-alcoholic steatohepatitis. Most common finding is in asymptomatic patients. In most of them, it's an incidental finding. Most of the patients are diagnosed either when they go to emergency room complaining of abdominal pain. An abdominal ultrasound is performed, and they notice, well, you know, you also have fatty liver. And as you know, most of them are asymptomatic. Almost all of them are going to have hepatomegaly, and the laboratory test abnormalities are going to be ALT and AST. Usually ALT is going to be higher than AST. If you see a patient with an AST higher than ALT, suspect alcohol. The alkaline phosphatase also is going to be elevated in a third of the patients, but bilirubin, albumin, and prothrombin time are going to be normal. Interestingly, also ferritin is going to be elevated, and we are also going to find positive nuclear antibodies in low titers. The diagnosis is very simple, as you know, as its definition and its name says, non-alcoholic fatty liver. So the presence of fatty is very easy to demonstrate with imaging studies. With an ultrasound, we can demonstrate, okay, it's fatty liver or CT scan. That's not a problem. What sometimes becomes a problem is to establish the non-alcoholic nature of the disease. How much alcohol is going to be bad for the liver, and when it's alcohol, but it's non-alcoholic. Well, the numbers that we usually take are more than 30 grams a day for males and more than 20 grams a day for females is going to be toxic for the liver. However, all this is very arbitrary because of, and it has been very difficult to establish because of different patterns of drinking. For example, if we take a medical student probably drinks 2 to 3 bottles of tequila during the weekend, but doesn't drink from Monday to Friday because he has to go to school and study. Contrary, we take a lawyer, for example, a lawyer might drink Monday to Friday, but doesn't drink Saturday or Sunday because he has to be at home with the family. However, most of the time we are able to determine the non-alcoholic nature of this disease. This is an example of abdominal ultrasound of a patient with a fatty liver. We can see a hyperechoic liver. And this is a CT scan, which is more objective. You can see here, this is the cut. You can see the spine here. You can see the stomach full of contrast. That's why we give contrast to distinguish different organs. And we see the spleen below the stomach, and this large organ here is the liver. Normally, the spleen has to be the same color as the liver, but here you can see that the liver is much darker. Why? Because of the presence of fat deposition. The gold standard for the diagnosis of non-alcoholic steatohepatitis is a liver biopsy. You cannot diagnose non-alcoholic steatohepatitis with a CT scan or with a fibroscan or with an MRI. The only way is by doing a liver biopsy. And here we have an example. On the left, we have a biopsy of a patient with simple steatosis, but without inflammation. You can see very nice hepatocytes with fat droplets, no inflammatory changes at all. It looks beautiful. On the other hand, this is a patient with NASH or non-alcoholic steatohepatitis, and these are the classic changes that we see. We see ballooning of the hepatocytes that we see here in this one, and the presence of Mallory bodies, lobular inflammatory response, and also sinusoidal fibrosis, or what we call the chicken wire fibrosis. So a question is, should we do a liver biopsy in any patient with fatty liver? I don't think we have enough liver biopsy needles or enough pathologists to read all the liver biopsy that we would end up doing. So when should we do a liver biopsy in a patient that has NAFLD? Well, in patients that have the metabolic syndrome, because these are the ones that have the higher risk to develop NASH and advanced fibrosis. I personally use the NAFLD fibrosis score that created by Dr. Angulo, and which is very helpful and can lead you towards performing a liver biopsy. Another indication for a liver biopsy is when you have a patient with fatty liver, but you are a competing diagnosis that you don't know if this is fatty liver or this is autoimmune hepatitis or something else, then a liver biopsy is indicated. I personally ask the surgeons during the bariatric surgery, since they are there already, I ask them to do a liver biopsy in these patients. Also, patients that undergo a cholecystectomy, I ask the surgeon, can you please do a liver biopsy during the surgery? This study is from gastroenterology, painful study from Dr. El Serrat in Houston, and he did a study in patients that were discharged from the VA hospital. This was over 300,000 patients, and he followed them for 14 years. And he saw that the patients that had diabetes had an increased risk for the development of hepatocellular carcinoma, different for patients that did not have diabetes. And this is because of the development of fatty liver, NASH, in the setting of insulin resistance and diabetes. Recent studies in the last years were seen a case series of patients developing hepatocellular carcinoma in patients with simple fatty deposition without cirrhosis. And you know that hepatocellular carcinoma usually happens in patients that have cirrhosis. So this case series have shown patients with simple steatosis and the development of hepatocellular carcinoma, as you see in this patient. You can see they're pretty normal liver, but now with a hepatocellular carcinoma in the right lobe. This is worrisome because now how should we survey these patients? We cannot be doing ultrasound in all the fatty liver patients. The natural history of the disease has been difficult because of lack of prospective studies with long-term and with histologic follow-up. However, this is from the best 5 studies I could find. And they show that if a patient has fatty liver, is going to have histologic stability in 59% of the cases. In 13%, there's going to be some improvement, but more worrisome is that 28% is going to progress to cirrhosis. Management is going to depend on if the patient has NASH or has simple steatosis. If a patient has simple steatosis, prognosis is good, and you should only treat the metabolic syndrome, mainly obesity, hyperlipidemia, insulin resistance, and diabetes. And if the patient has NASH or steatohepatitis, try to aim at improving liver disease, and we are going to talk in the next slides. There are multiple therapies that have tried to be being developed for the treatment of NASH, starting with weight loss and lifestyle modification. Weight loss also with using medications, insulin sensitizing agents. Since insulin resistance is a problem, why not use insulin sensitizing agents such as metformin and glitazoles? Well, if there is an imbalance of the oxidants and antioxidants, why not use antioxidants like vitamin E, betaine, N-acetylcysteine? If the patients have fatty liver, why not use lipid-lowering agents? If there is TNF-alpha, why not use TNF antagonists as pentoxifylline? If intestinal flora plays a role, why not use probiotic? So, etc. And unfortunately, there are multiple studies that have been done, but most of them do not fulfill the requirements for a good prospective randomized control study. Most of them do not have histologic information. So still we are lacking of good basic design studies for to try to use any medication in these patients. And also disappointing results also haven't helped us for any recommendation in patients with NASH. And also most of these studies use surrogate markers for clinical outcome and not really histologic studies. So I'm going to mention a few studies that have been done, the best ones, and with some results. How about weight loss and lifestyle modifications? If most of the patients are obese, why not try weight loss and exercise? There are two different studies. One by Dr. Pomrat that compared diet and exercise with structural education. He took 31 obese patients. And contrary to most of the studies, these are biopsy proven. He did a biopsy before starting the study and a biopsy at 48 weeks. And what he found that patients that underwent diet, exercise, and behavior modifications show significant improvement in steatosis, lobular inflammation, ballooning, NASH activity score, and weight reduction. The other study was also biopsy proving. It showed biopsy before and biopsy after, 6 months after. And this one compared standard of care, basically nothing, compared it with low fat and exercise, moderate fat and exercise only. And what they found in this study is that regardless of any intervention, meaning exercise and different diets, regardless of anyone, there was improved in liver histology. So standard of care, there was no change at all. So now I think it's important weight loss and exercise for these patients. However, there is a problem that adherence to lifestyle intervention can be problematic. Not everyone likes to do exercise. For example, in this study, only 15% of the patients were able to achieve weight loss, only 15. And why? Well, most of them say that they were too tired to do exercise. And even some, excuses, some say that they didn't feel confident enough to start a regular exercise. So, this is, I tell my patients, exercise has been shown to be helpful and it's free. It doesn't cost anything. I think exercise and lifestyle modifications should be recommended to all the patients with fatty liver, with NASH, and also primarily to modify their cardiovascular risk, insulin resistant, and liver-related risks. Coffee consumption has been shown to be helpful for the liver. Initial studies show that patients with alcoholic liver disease that drank coffee had a less aggressive disease. So then there were studies in the HALT-6 study. It's a multi-center study in patients with hepatitis C. And it also showed that patients with hepatitis C that drank coffee had a less aggressive disease than the ones who didn't. And now we see that in NASH, these are two studies comparing patients drinking coffee and patients without drinking coffee. And for example, this one is from the NASH research network, and it showed 782 adults, and it showed that coffee intake was inversely associated with advanced fibrosis. And also, this is from the Army in San Antonio. 306 patients also showed that coffee consumption was associated with a significant reduction in the risk of fibrosis among NASH patients. However, it's not only to drink one cup of coffee now and then. The minimal amount of coffee that you need to drink is 2 to 3 cups of regular coffee every day. How about the glutathione or insulin sensitizers? The pioglitazone is the one that has been studied the most. And studies have shown that pioglitazone is capable of showing histologic improvement, not so much in fibrosis, but all the studies showed histologic improvement, including this one is the study that was done with vitamin E. And due to this, now the AASLD practice guidelines included pioglitazone in the treatment of NASH. Initially, they were reluctant because they didn't want to recommend pioglitazone in non-diabetics, but looks like now recommendations changed, and pioglitazone can be used to treat patients with and without diabetes in biopsy-proven NASH. Of course, risks and benefits should be discussed with each patient. The insulin sensitizer might cause weight gain. In some studies can show to cause bone loss, and in one study showed an increased risk for the development of bladder cancer. It should only be used in patients with biopsy-proven non-alcoholic steatohepatitis, not for simple fatty liver. Vitamin E is also has been as an antioxidant, was tested here in the PIVENS clinical trial, and they compared here pioglitazone, vitamin E, with placebo, and showed that vitamin E decreased aminotransferases, and it also improved steatosis, inflammation, ballooning, and resolution of steatohepatitis. However, there was no much effect on hepatic fibrosis. AASLD practice guideline included vitamin E in the recommendations. Vitamin E improves liver histology in non-diabetic adults with biopsy-proven NASH, and therefore it should be considered as a first-line pharmacotherapy. After this, there was a study published in JAMA that showed that patients taking more than 800 international units of vitamin E had an increased risk of overall mortality, which later that was not proven in further studies. And also another study using vitamin E for prevention of prostatic cancer showed that patients taking vitamin E showed a slightly risk for the development of prostate cancer. However, this doesn't seem to be reproduced in other studies. Obeticholic acid, the new kid in town, the Regenerate study, studying over almost 1,000 patients now, patients with fibrosis, comparing with placebo. And in the last Hizo meeting in Europe, study showed that patients taking obeticholic acid, they showed improvement of fibrosis, at least in one stage, in 23% of the patients. And it showed no worsening of non-alcoholic steatohepatitis after 8 months. This is during the first interim study. This study is still going on. It's a long 5-year study. And main side effects from obeticholic acid is itching. 30% of the patients presented with itching, and some of them with elevated low-density lipoproteins. The statins or HMG-CoA reductase inhibitors frequently are discontinued in patients with fatty liver because of abnormal liver tests. They have been used in the treatment of fatty liver. However, the studies that were done with the statins had no histologic endpoints, were not randomized control. However, the statins significantly improved cardiovascular outcomes in patients with NASH. So if you see a patient with abnormal liver tests and fatty liver, taking statins, continue the statins, which most of it's going to be helpful to prevent cardiovascular outcomes in patients with NASH. It is pretty safe and treating hyperlipidemia in patients with fatty liver. And these are the most recent trials, not very exciting. Most of them haven't been shown to be very helpful. For example, we see that selensortib failed already in the Hizo, not very promising. Obeticholic acid, as I mentioned, is the only one. Fibranor and cenicriviroc looks like still work in progress, but still we don't have any silver bullet to treat non-alcoholic steatohepatitis. So obeticholic acid so far is the only one that has shown some benefit, and still we need to wait for the finals. Well, how about surgery? Well, we know that the demand for weight loss surgery in the United States has increased significantly over the last years, as you see here. And the most popular has been the Roux-en-Y gastric bypass. The adjustable gastric band was used, but there were several complications. One that is also becoming popular now is the vertical sleeve gastrectomy. Biliopancreatic diversion with duodenal switch also, and the ileal bypass also has been abandoned because they on its own can also cause liver disease. Studies using bariatric surgery for NAFLD having quite a bit. This is a meta-analysis of the best 15 studies using liver biopsy in these patients. And most of the studies showed pretty good results. A decrease in mean BMI after bariatric surgery, also improvement or resolution of steatosis in 91% of the patients, resolution of steatohepatitis 81%, fibrosis 65%, and a complete resolution of non-alcoholic steatohepatitis in up to 69%, which this is a pretty good results. Steatosis, steatohepatitis, and fibrosis improve after bariatric surgery. However, we cannot do surgery in all the patients with fatty liver or with NASH. So having said that, what to do with a patient that presents with fatty liver or NASH to your clinic? What should you do? Well, my recommendations are exercise regularly and seriously 5 days a week. And you can start with daily walks. If a patient that has no limitations, they can go bicycle, running, or any type of exercise regularly 5 times a week. I tell again my patients, this is 100% guaranteed that's going to help your fatty liver, is going to help your insulin resistance, is going to decrease your risk for cardiovascular disease in the future, and it's free. Number 2, a well-balanced diet also. It is also free and 100% that is going to help. I personally recommend a Mediterranean diet. It's not so strict, and patients have a lot of liberty, and it is very palatable. And studies have shown quite a benefit with a Mediterranean diet. Weight reduction, I recommend slowly, lose weight slowly. We have patients that they have a wedding and they want to wear a new dress and they lose 30 pounds in 2 weeks, but after the wedding, weight goes up. What I recommend, lose 10% of your weight in 6 months, and that's pretty good enough to see improvement in insulin resistance and lipidemia and fatty liver. Tight control of diabetes mellitus, as well as tight control of hyperlipidemia. Try to avoid alcohol. As you know, alcohol will causes fatty liver. Coffee, if you don't have any contraindications, take 2 or 3 cups of coffee, preferably in the morning so you can sleep at night. Also, decrease fructose intake. Fructose is a very cheap carbohydrate that it has a very high caloric index, and also it's converted to triglycerides. And I think it's the one to blame for the obesity epidemic that we have now. Fructose is used in all the carbonated beverages and in many foods. So important to decrease fructose intake. Also, in patients with NASH, biopsy-proven NASH, you can start with vitamin E, 800 international units a day. That's what the Pivens trial used. Or you can use pioglitazone, also in patients with biopsy-proven NASH. Discuss the benefits versus the risks. And bariatric surgery, not in everyone, but I usually recommend it in patients that have a BMI of 40 or more and that fail diet and exercise. This is with or without drug therapy, or in patients that have a BMI of more than 35 that have obesity-related comorbidities, such as high blood pressure, impaired glucose tolerance, dyslipidemia, sleep apnea, etc. Don't forget to do surveillance for hepatocellular carcinoma in patients with cirrhosis. In patients with non-cirrhosis, we don't know. I usually do one abdominal ultrasound a year in patients with simple steatosis. The take-home message, I think, from this talk is that fatty liver is a significant public health problem. It is related to the metabolic syndrome, it's part of it. And still, we need a better understanding of the pathophysiology of non-alcoholic steatohepatitis. And urgently, we need prospective, randomized, long-term controlled trials with histologic follow-up to assess.
¿Me escuchan ahora sí? Si alguien me puede escuchar. Creo que teníamos algún comentario. Muy bien, vamos a tener aquí una solicitud, Laura Castro. Muy bien, adelante, Laura.
Gracias, Gonzalo. Buenos días. Tenemos una solicitud para Gabriela Durazo que le haga llegar 2 preguntas a su hermano. El doctor Durazo es un experto en trasplantes e independientemente de todo lo que mencionó, para gente que tiene hígado graso y que tiene NAFLD o que tiene NASH, todas las recomendaciones que él hizo son aplicables para todos nosotros que supuestamente no estamos todavía enfermos, pero que debemos observar: el bajar de peso, la dieta mediterránea, controlar la presión arterial, controlar la hiperlipidemia, eso pues lo sabemos todos, supuestamente estando sanos. Pero yo tengo 2 preguntas que le quiero pedir a Gabriela, que en su momento se las pase al doctor Durazo. 1, quisiera saber cuál es la situación de trasplantes en México, porque como ustedes saben, pues México está siempre un poquito atrasado. Y yo quisiera saber si hemos hecho progresos importantes, estamos en pañales en lo que es trasplante de hígado, y el doctor Durazo es un experto en eso y me gustaría que nos lo dijera. Y por otro lado, habló de una medicina que se llama ácido beticólico, que me interesaría saber si está disponible en México. Y sobre lo demás, todo lo que él mencionó creo que es muy aplicable para nosotros que estamos como intérpretes traductores sentados 8 horas frente a la computadora, pues todo aplica, ¿no? El bajar de peso, el controlar la tensión arterial, etcétera. Pero bueno, esas preguntas podríamos pedirle, quizá Gabriela Durazo pudiera intervenir y nos dijera si está de acuerdo conmigo que sería importante el saber estas cuestiones y poderlas preguntar a su hermano.
Muy bien, pues transmitiremos las preguntas. No sé si hay algún otro comentario y con mucho gusto se lo transmitiremos al doctor Durazo. Si no, pues les agradecemos muchísimo su participación en esta primera conferencia del día de hoy, la 9ª sesión de la Convención Nacional de Intérpretes de Conferencias, y los esperamos a las 10 con el futuro de la interpretación simultánea a distancia, con Katy Kaufman, y a las 12:30 con los lenguas in memoriam, que estará dividida esta actividad en 2 sesiones. La primera, un homenaje a nuestro queridísimo colega Guido Gómez de Silva, que en paz descanse, y después la presentación de la nueva publicación del Colegio Mexicano de Intérpretes de Conferencias, Los Lenguas in Memoriam, que es una publicación muy bonita para después dar lugar a la clausura. Agradecemos nuevamente su participación y estaremos en contacto. Muchas gracias. Veo que aquí hay un mensaje. Déjenme leerlo antes de apagar. Nada más, muchas gracias. Muchísimas gracias a todos. Buenos días y nos vemos en un ratito. Gracias.